Our next speaker in our professional development session is a cardiac surgeon. He's associate professor at the University of Kansas School of Medicine here in Wichita, and is internationally recognized for the innovative practice and research in patient safety, high reliability,
it's 12 hours.
Healthcare teamwork with active engagement of patients and families, and interpersonal professional education. His research utilizes social science methods with the social construction orientation to study just how healthcare can be intentionally transformed through collaborative approaches. In addition to his work in healthcare, Dr. Uhlig has a lifelong interest in aviation, and he holds an airline transport pilot license and is a certified flight instructor. Please join me in welcoming Dr. Paul Eulig, and he's going to be talking to us moving from 1 star to 3 stars, the principles and processes available to any CV program.
Susan, thank you very much. And can y'all hear me okay? Wonderful.
Yes.
I am really honored to be part of this. And I did have the privilege of actually practicing with Susan for a number of years here in Wichita. And it's just been so fun to watch your career just rocket to way beyond 3 stars, Susan, and all the good that you and your colleagues are doing. And I'm honored to try to help with that today. I wanted to just take a minute about my own teaching philosophy. And that is, there would be one approach where, like, the teacher's here and people are here and you're passing this information. And it's not the way that I tend to think about it. And the other, when I teach with medical students, I call it the 3 blinks from now philosophy. They're going to blink once and they're going to be graduating, and they're going to blink another time and they're going to be finishing their residency, and they're going to blink the 3rd time and they'll be giving this talk. And I love it that way. We are all colleagues. Any one of you could be giving this talk maybe today or maybe a few years from now, but this is about kind of shared learning. And so if you could think of it that way, that this is a little bit of some of our journey. It's been really interesting. Maybe some of those things will be useful to you. Maybe you'll be able to take those and make them like 10 times better. So that's kind of the way that I want to think about this. So I'm going to go ahead and share my screen here. And it's waking up, so I just wanted to make sure that you all can see that. Are you able to see that okay yet? If someone could give me verbal on that, that'd be great.
Yes, just show it to the viewing presenter view.
What's that?
Just show the presenter view.
Okay. Is it there yet?
Not yet.
Okay.
We just see your slides.
You can't see them?
We just see the slides part.
Oh, you see the slide. Okay. That's all I want to show you. So I'll just talk away. I'd be happy to be behind in the background. So let me just start the slideshow. So the title, as Susan said, is Moving from 1 star to 3 stars. And of course, that's referring to the STS database, principles and processes available to any CV surgery program. And I don't have anything to disclose regarding this, but many to thank. And for today, a ton of the gratitude goes to colleagues that I worked with when I was on the faculty at Dartmouth and directed the cardiac surgery program at Concord Hospital. Eric Riddell was a patient that we cared for, who then became just absolutely a crucial member of our team as we went forward with many of the things that I'm going to describe today. Elise Kendall, one of several pharmacists there, Addie Camilio, a social worker who was really the heart and soul of many of the things that we're talking about. Jeff Brown, an extraordinary safety scientist who joined our team and just taught us so much. And here's a slightly younger version of me. And you see these smiles in all these people. Eric sadly passed away last year, and just so want to honor him and everything that we're talking about today. So I'm going to start by asking a question. I'm really interested in you thinking about something that you have personally learned how to do well, and about how you learned how to do that. And what I'm showing you here is a couple little pieces of scrap steel that I stuck together with my little TIG welder as I'm learning how to weld. And if you look at it, it's actually not too bad a weld here, but you start looking, this is the little heat signature. You can see a really good welder, this would be smooth and even, but you see it kind of spreading out. I was getting really too hot as I was going here. Maybe some of you do woodworking and you're making a dovetail joint, or maybe you're learning how to plant a garden, or maybe you're growing a family, or you're learning how. A wonderful presentation just preceded this one. You're learning how to take care of yourself. I'm really interested in how people learn. And I wanted you to just think about something that really matters to you that you've learned how to do, and reflect about how you learned to do it. And I was giving a talk not terribly long ago about this, and I asked the audience to do that. And a person in the audience, the very front of the audience, a delightful little lady who was probably in her later 80s, her hand shot up, and she was describing how she had learned how to knit. And this is what she said. She said, well, you just do something, you see how it turns out, you think about how you could do better, and you try again, and you just keep doing that. And it was so fun, and the audience just loved her, and I loved her description, because that's exactly how I've come to this middle point in welding. I just tried it, I looked at it, pondered how I could do it better, tried it again. And of course, you hear in this, PDSA cycles, all sorts of stuff. And I wanted to just show a little schematic that our research team calls the learning loop. There is some kind of work that you do, and then some type of observation. Doesn't have to be fancy, doesn't have to be measures or whatever, but some way. Are you going to do it? You're going to look at it, you're going to ponder it, and you're going to think what you could do better, and then you're going to try it again. And this is what people do all the time. I'm a little kid, and I'm going to touch this hot stove. Oh, I don't like that feeling. I'm never going to touch a hot stove again. And so over time, you see this growth of capabilities. And it really is this connection between action and reflection and change that produces this learning. And so I wanted to just hold that in mind, because we have a ton of learning like this at an individual level in healthcare. In fact, that's how mastery is achieved. You all probably know those little things that have kind of caught on in the last few years about mastery, 10,000 hours of practice. And what mastery really is acquiring rich tacit knowledge of something. Tacit knowledge is embodied knowledge. It's something that you can't go look in a book about. It's something that you acquire over time from doing things. You can't pass it along exactly. You can guide people in the acquisition of it, but it's something that you have to learn. I could read everything that there could be published about playing a violin, and I would not be able to play the violin until I went through those many, many hours of practicing and learning and thinking about it and trying it and doing it again. And so our little research team came up with this little thing that we have hovering over this individual person, this little field that shows this tacit knowledge that this expert violinist has acquired over time. And so the question is, how do teams learn? We all work in collaboration with others. I am of absolutely no use as a cardiac surgeon without the perfusionist, without the scrub tech or scrub nurse, without the circulating nurse, without the anesthesiologist, and beyond that, without the ICU and the post-op floor and everything else. We have to work together. And yet, how do teams acquire this same embodied tacit knowledge that individuals are learning all the time? And so in order to think about that, I have just a little, I don't know, thought situation for you. And it's a serious one. And I hope that it won't be too emotionally painful because some may have gone through this, especially with the year that we've had. But I'd like you to imagine that you're in a hospital room, but not as a healthcare provider, but as a kind of a family member of someone that you love. As one of our nurse practitioners said, someone who is your everything. And it's the two of you in that room. You have that person that you love, and you are there, and something goes terribly wrong. And fortunately, in this hospital, you've been taught about how you can activate a rapid response or a cardiac arrest. And you see the button on the wall, and you push it. And in just a few minutes, you hear outside your door 3 different teams that have come to respond. And your only job in the world right now is to open that door and choose which team you want to come into the room. And I'm going to tell you about these teams. All of the teams have extraordinary individuals who have achieved mastery in their profession. Each team has 5 people. Each team has a physician, has a critical care nurse, has a respiratory therapist, has a pharmacist, and has a chaplain. And they're all just, impeccably individually trained. But I want to tell you about the difference in the teams. The first team, those 5, when they came in this morning, they found their counterpart. For example, the physician found the physician, and they took the code beeper from that person. The nurse took the code beeper from his colleague, and the pharmacist, and so forth. And the alert just came, and the beeper went off, and they have arrived outside your door ready to care for your loved one. That's Team A. Team B, they've shown up, and they are also wonderfully individually trained. But in this particular case, this team, they started working together a week ago. In fact, they're going to work together for an entire month. Whereas Team A, tomorrow's team is going to be a totally different team. Team B, tomorrow's team is going to be the same people. And they've been together for 7 days, and it turns out they've had 1 cardiac arrest each day. So they've done this 7 times, and they're here ready to offer their services. Team C, exactly the same kind of situation in that they started a week ago, but here's the difference with that. When they showed up a week ago and picked up their beepers, they didn't just go about their ordinary work. They met in the simulation lab. The previous team signed out to them and talked about all of the arrests that they had been caring for the past month in the hospital. They prioritized those. They had organized a training program, and Team C went through basically rehearsals of all the types of cardiac arrests that the previous team had cared for. They also now have had 7 cardiac arrests over this past week. But after each one, they went back, they debriefed it together. They worked out in simulation all the things that they would do differently, and they are now outside your room. And so the question is, at this one most crucial moment in your loved one's life, which team would you like to have come in the door? Are you going to invite in Team A, Team B, or Team C? And the question is, is it a hard question? And I would say it's probably pretty easy to decide which team you want in. I would certainly want Team C to come in. And the question is, why? And the answer is because there have been conditions that have been created that Team C has not only their individual skills, but also has kind of the collective learning that is possible if conditions are right for that. So what I'm going to suggest, and kind of the basis of a lot of the research and the talk that I'm giving today, is that team level learning requires an infrastructure that is missing in most clinical environments. We've got plenty of workflow, in almost every place where I've been. But in terms of how that workflow is structured, what the team is like, whether today's team is tomorrow's team, and then whether there is any kind of structure for that team together as a team to say, hey, how do we do? Let's think about that. Let's see what we can change, and then let's modify this learning loop. This infrastructure for team level learning is kind of what we're talking about today. And I'm going to suggest to you it's something that you can build, and that if you do build it, you're probably going to be astonished at the improvement in your team outcomes that happen as you do so. So now I'm going to go back to Concord. This is this wonderful award that we received in 2002, so it's almost 20 years ago now. We received one of the inaugural Eisenberg Patient Safety Awards from the Joint Commission and the National Quality Forum for our work implementing this collaborative care model in Concord. So it was a community cardiac surgery program. I was on the faculty at Dartmouth, but outposted to the state capital of Concord to run this program. And we began asking ourselves, how could we make a question that we heard regularly go away? And that question was from our patients and families: don't you people talk to each other? And of course, we were asked that question because it seemed to people like maybe we didn't. Of course, we did. We talked to each other every day and everywhere that we possibly could. And yet the net effect of it, because of the individual way that we worked, patients would say, well, you say maybe my surgery is going to be today, but the nurse said probably that's not possible because of this dissection coming in or something. And then they said, and all these, so everybody's kind of doing their best to give information to the patient family, but it's not really, aligned always. And so we tried to think, how could we make this better? And we did a series of things to try to improve that. And as we did, our outcomes started changing. This is our expected, which is this line, and this is our observed mortality over these series of cases. And we were really quite a good program. We were embedded in something that many of you know as the Northern New England Cardiovascular Disease Study Group. The program had been created by Dartmouth, and we were achieving what at that time were among the best outcomes in the country, exactly doing what was expected for us. And yet, as we made these changes in how we worked, this little triangle right here, this is living people that would have died if we had done what we were doing. And so I am so sorry for the talking head part of this. When I give these talks, I so much prefer to be interactive with you all. And I don't know quite how to do that, but we'll have a chance here in a little bit to maybe do that more. But if you're getting bored with any of this, I apologize for that. But just stick with me because I think it will be sort of interesting, but I just wanted to tell you that. So we got this award and we wrote this article, with the help of the Joint Commission folks and everything. And we were emphasizing our collaborative rounds, the different things that we were doing. And as people tried to copy those things, they did not usually get the same outcomes that we did. And so the question became like, okay, what are we missing? And so this really extraordinary thing happened is that we got some funding from the information system at the Mass General, information system department at the Mass General Hospital to study our collaborative care. And we created something that we called the Way Cool X Team. It was a social science research team. Here's some of us, and here we are working and trying to understand. We observed, interviewed, and videotaped care teams working in traditional ways, and then across the spectrum of people working toward this collaborative care model. A safety scientist, a cognitive engineer, knowledge manager, you can see all the different folks that we were able to bring together. And from that came a set of insights, a set of data. Here's an example of some of the things that our program was able to do. We were in this Northern New England cardiovascular disease group with other hospitals across Maine, New Hampshire, Vermont, and some in Northern Massachusetts. And all of us were trying to do some of the similar things. Like at that time, we were really trying to reduce our time to extubation postoperatively. Here are the other hospitals in that consortium. The blue is our collaborative program. And you can see that there was a reduction in time over this to extubation among this group. But here's what our little program was able to do. It was just like extraordinary. We kind of went to from pretty much where everybody was to pretty much extubating everybody in the operating room. It wasn't that we were any better than these people. It was that we had a collaborative infrastructure that they didn't have. Every week we sat down together and thought about how are we doing, what are our outcomes, how could we do even better. And in that context, we were able to do things that other programs just weren't able to do. And it also was exciting. It felt better. Here's a survey that one of our nursing graduate students did about quality of work life, sense of common purpose, personal collective power, active listening, responsibility for leadership. And you can see this shift compared to the traditional. And so I sometimes enjoy thinking about things outside of healthcare. And one of the things that I loved when I was a boy was my grandma. And she loved to make pies and different things. And so I went home as a college student and I watched her make a pie crust. And this is my handwriting. I carefully made a little recipe card watching my grandma. I don't know how many of you make pies or pie crusts, but if you look at this, you can see that this 19 or 20-year-old kid missed a whole lot. You take some flour, you take some salt, you take some Crisco, you take a little water, you combine them, and you bake them. And it's in this combine, where the magic is of that pie crust. And I was like totally oblivious to that. And so that saying, easy as pie, has always been really interesting to me. And our collaborative care model, it was kind of the same. What we were really doing, we absolutely did not get it right in this, what we were writing. It took the multiple insights of this research team to point to what was actually shifting in our environment. And one of the most interesting moments of that insight was there had been a new heart surgery program created by the Mass General in a little town of Salem, Massachusetts. They got a certificate of need, started a new program. They actually physically built all the new operating rooms and the ICU and so forth, and they hired all the staff. And they got out of sync between the construction and the hiring. And they had hired everybody, but they didn't have the building open. And I can't remember how it exactly happened, but their entire team came up and worked side by side with us in Concord, about an hour north of Boston, for about almost 2 months. And then their program opened and they went off and started their new program, and we sort of lost touch with them. And now 2 years later, we have our research team and we're trying to think through, where can we go to see people who are beginning to work in this different collaborative way. And we suddenly went, oh, what about those people from Salem? And so we called them up and they said, oh, we would love to have you come. And we started looking at their outcomes and talking with them about that. And they had blown us away in terms of outcomes. They had this brand new program. By the time we visited, they'd done 322 cases in their first year and a half. Half of those cases were ordinary CABG, but half were more complex cases. CABG valve, double valve, redos, and they had 15 circuit arrest arch or MI arch replacements in that group. And they had had one death, 0.3% all case mortality in this brand new program. So we were so excited to go see them, and it's just like incredible. And Tom Vandersholm was the surgeon, and I was visiting with Tom when we first arrived, and I said, Tom, we cannot wait to see your collaborative rounds and how you're achieving these wonderful outcomes. And he looked at me and he said, our collaborative rounds? I said, yeah, I think you're doing that, aren't you? And he goes, yeah, we're doing it. But Paul, do you think that's the reason our outcomes are so good? And I said, well, I thought so. And he said, well, yeah, we do it, but Paul, it's all the other things that you taught us. It's the weekly team meetings and looking at our data and getting everybody together, building this cohesion among everyone. It was just like, oh my gosh. It was just like all these things that my grandma was doing that I did not see. And I was the one doing them. And so the research team took it forward from there. And so there's kind of a model now. We call it the social field model of collaborative care. And so here's a little illustration of some of the things that we think that we've learned. That really high performing clinical environments, and we talk about teams, but it's really the environment itself. That grows over time, almost like a garden. If you set a set of preconditions in place, and then people start to interact and reflect, and team level learning starts taking place, and these capabilities of reliability and resilience start to grow. Now, there are certainly some individual skills and some individual skills for teamwork that can be taught, things like team steps and so forth. But our research suggests that these really high level skills, truly having shared mental models, of truly developing trust and psychological safety, of having a shared capacity to act and monitor and predict and respond, and then the highest level of all, the shared capacity to break the rules, to create new rules in unique situations, that all of these are really team level capabilities, collective capabilities that grow. And so we coined a term, we call it social fields. And we're using the same little thing here that we had over an individual, but now we've got over a group of people. The living collective intelligence of a care team, consisting of memories, wisdom, emotions, patterns of interaction, arising over time from shared experiences, reflective conversations, and team learning. So mastery at this team level, it's still the same. It's rich tacit knowledge, but it's of the team itself. And this is the thing that is, we think, missing in most environments and is so possible to create in your own environment. And so we use this little phrase, where to put the wrench to create these things. And these are the things that we kind of boiled it down to, is organizing for teamwork. And I'm going to take just a minute and talk about each one of these very briefly. So organizing for teamwork is like, you can have an environment, let's say that you've got a great big ICU, and maybe there's trauma, neuro, and heart, general surgery, whatever. And maybe you've got a huge post-op floor, and so you've got all these different nurses. They have different skill sets, different interests. You've got a social worker who tries to help with this, and you've got this pharmacist or that. And in many environments where I've worked, it's sort of like a random pairing. You get wherever there's a bed available, you get that nurse. Whereas in Salem, for example, they built one unit. It was an acuity adaptable unit. They changed it from an ICU to a floor, depending on what the patient needed. And they had the same little team of people caring for every patient that the heart program cared for. And they were ICU nurses today, but it was the same social worker, same pharmacist. So they took this potentially a great big random universe, and they shrunk it down into smaller, more relational groups. It wasn't always the same people every day, but it would be one of these 15 nurses or one of these 2 pharmacists or one of these 2 social workers, so that people were actually able to get to know each other and understand the patterns and the interactions and capabilities. So this we've found it to be like huge. Also, the leadership styles. Many of us were trained in kind of a command and control kind of leadership. Heart surgery lends itself to times when that is required. And yet, for many of these other things, a much more collaborative kind of leadership, not just one leader, but multiple leaders across professions, with that leadership flowing to whatever the the expertise need is at the moment. It's a very different kind of thing. It's about giving away one kind of power to gain a different kind of effectiveness, a much better kind of effectiveness. Weekly team meetings. Now, none of us like to go to meetings, but actually in the places where we have created these sort of system meetings, those become some of the most happy times of the day. Again, thinking back to the earlier talk, opportunities to actually connect and know the people that we're working with in a different way. And it's much less structured. It is a time together to connect, to reflect, to think about change. We found that it's better to not have the like the designated leaders like the surgeon or the nursing manager running those meetings. It's better to pick somebody like at University of Cincinnati when we were creating this kind of replicating this work. It was our chaplain who was just like natural at running this. In several places, it's been nurse practitioners who are awesome at running it. In one place, it was a physical therapy assistant, and that was at Wesley. I'll talk about that in just a minute. A daily collaborative rounds process. It doesn't necessarily need to be collaborative, but some sort of a routine for the daily care. Now, if you're in the operating room, that's one kind of daily pattern. If you're on the floor, it's a different daily pattern. If you're in the ICU, but something that everybody can know and count on in terms of the time and what their responsibilities are and where everyone will be. So often it's like, well, whenever the surgeon comes, I guess I'll know what that person wants to do. So actually changing so that that becomes consistent and predictable. Active engagement of patients and families. Something that we call down and in data. So like we all live in data worlds, but it's usually up and out. It's like at the end of the day, we turned this data in and went to the quality department and we never heard about it except that 6 months later, they got mad at us about how come our costs were too high or whatever. This is like, what are we really interested in? And can somebody bring that to us in real time so we can sit down this week and talk about it? It's a really kind of fun thing called glitch process. And then I'm going to come back to both of these in just a minute here. But then intentional, strong connections with the large organization. Because if you build this frontline thing like this, you're going to get out ahead of your environment. So what this is really about is setting a stage for ongoing cycles of action and reflection. So here is the team at Wesley that I'm going to talk about, where we basically replicated what we did at Concord. And here is different people, pharmacist, here's the physical therapy assistant, former Wichita police officer who had a midlife change of heart and career and took his schooling in physical therapy assistant, but he had this natural affinity and respect of everyone, and he became kind of our rounds leader. Many other different people, nurse practitioner, a couple of the floor nurses, cardiac rehab, nurse educator. And here are those same folks now in the weekly meeting. This meeting doesn't exist in most places where I go. This does, kind of, but this doesn't. And so they're constantly moving from, what are we going to try this week? Let's try it. Okay, how'd that go? Okay, let's change this. Let's do this. So these cycles of action reflection set this up. And then this down in data informs things we're curious about. And it's available in near real time. And then this little thing that we call glitch, gathering little insights that can help. It's a pause every day at some point in the care process to sort of say, hey, Mr. Smith, hey, team, how did everything go today? Was there anything at all in our systems and processes that didn't support us the way that we wanted? Here are some examples of glitches. Medication orders being faxed to food service instead of the pharmacy. Okay, let's in our meeting, let's talk about it. Let's move the speed dial button on the phone so they're at the opposite corners because they were right next to each other. People were mistakenly hidden. The light in the shower is dim. Okay, we put a brighter light bulb in the shower. We gave one patient's insulin to a different patient's. Why was that? Well, the printer label was broken. The tests were mislabeled. We've ordered a backup printer. Cool. Blah, blah, blah. It goes on and on. When we put a brighter light in the shower, we could see there was mold there. Oh my, new cleaning routines in the shower. So you can see how every day at every interaction, pausing and asking about glitches and then bringing them back to the team meeting, which we never had before. And you can see how all these little broken things that we were living with start getting better. And then other things. Here's the team at Wesley trying to figure out how can we include patients and families and keep a record of what we do. And so let's try this whiteboard. So it's not like the whiteboards that say your doctor is blah, blah, blah. This is like on Sunday, we're on epi, norenone, and amio. We're going to stop the CRRT and remove the catheter. Oh, by the way, he wants an egg McMuffin. He's eating really well. We got him on some cefepime. Platelets are okay. We need to watch it because we're on heparin. Stools are better. Yay! Activity. So we would create this in the rounds process with the patient and family. Routinely, we would have family members, when the next family member arrives, walking over to this board saying, okay, they're going to be weaning this norenone stuff off, and they're going to stop this kidney stuff. This became, and then tomorrow morning, that would still be on the wall, and we would go back and we would take up from there as we were doing the rounds. And then this would help me remember. This was Kathleen, and the patient's name was Ron, and he's an archer. So there's just all these little things that we do. And then we developed a little safety checklist, again, in ordinary language. What are we doing for blood clot prevention? What are we doing for blood sugar control? Lines and tubes, skin and wounds, nutrition, labs and cultures, what medicines? And we would go through this every day with the entire team, with the patient and family. And tons of stuff, that we thought we were doing, we were missing. So this is kind of showed things. So basically the journey at Wesley started in about 2009. I'd come back to Wichita by then, and I was doing some quality stuff at Wesley, which is one of the HCA hospitals here in Wichita, a much larger hospital, 450 beds, at that time around 250 hearts a year with about 6 surgeons. And the chief medical officer came to me and she said, oh my God, Paul, I just look at our STS data. We've been putting, information into this thing for years, but nobody's ever looked at it. I said, okay, well, that's not unusual. She said, yeah, but do you know what our percentile is for our composite quality score for ChemImage? We're 8th percentile in the country. 8th, like bad. She goes, we thought we were like maybe 80th. And she goes, do you know how to fix this? And I said, well, yeah, I think I do actually, but it involve a lot of folks and it should be kind of fun. She said, well, what would it take? And I said, well, why don't I become the medical director and let's start doing it. So we just went to the same patterns that we worked before, organizing for teamwork. So at that time, patients were going to a large SICU. They were going out to the post-op floor, wherever anybody had a bed. So we created some specialized units, a CVICU in the ICU and a PCU out on the floor. We developed specific cohorts of nurses who were interested in heart patients. We provided special training for them. Every one of those was a relational challenge. Oh, I don't want to just do hearts. I like to do trauma, but all these things, every one of them. I was the new medical director. There was a nursing director I knew and encouraged her to sort of help with this. We started weekly team meetings. Well, we have no time for that. There's no way we could possibly do that. We started this daily collaborative rounds. Well, you've got to be crazy to do this. We went to the quality department and began to ask them about some of this down and data. We talked about doing the glitch process. no way am I going to talk about mistakes or errors in front of patients and families. Are you crazy? Every one of these was like impossible. So here's kind of where we started, and I just want to go through this. So we had great individual knowledge and capabilities. And I'm going to skip down here. We had a fair amount of active engagements of patients and families, kind of the normal amount that you might get. We had really not very well organized stuff. We were in an ICU, that there were some people that knew hearts. We did have some pretty good leadership, but we didn't have any of these things. And we had some support from the organization. So I put our team level capabilities about here. And this is what we were achieving, 1 star. And so over the next several years, we started making these changes. We started getting the CVICU up, and then eventually we got the PCU up. We started working on the leadership. We were able to successfully get the weekly meetings going. It took a while, but we were able to get the collaborative rounds going. The quality department really kicked in and started giving us the data that we were asking for in these rounds. The glitch process was a bridge too far at first for everybody. But I stayed really close touch with the people that were creating and authorizing these environments and all the different leaders. And because of the rounds process, our patient family engagement started to move, and our team level started to move, and our STS numbers started to move. And then we continued that. We got the PCU up, all these things steadily improving, and we're solid 2 stars now. And then we continued. Now we had special training programs for the nurses. The weekly team meetings have really kicked in now. We made them over lunchtime. People loved coming to them. We started distributing the meetings and minutes and so forth. And everything is really coming well. And we're just on the edge of 3 stars. And then at that point, a really interesting change happened. And that was that one of the surgical groups in town decided that they wanted their own person to be the medical director of the unit. And they threatened to take their cases away from the hospital. And so the CEO called me in and said, gosh, you've been doing great work, but we're going to have to make a change here. And it was so socially destabilizing for all the work that we'd done. We still had the units and the training in place, but people were unsure about the leadership. People started trying to figure out if they should go to these weekly meetings. The surgeons had been going to an M&M that we created, but none of them had been going to the weekly meeting. I was the only surgeon who began doing that. The rounds continued for a while with a nurse practitioner that we had hired, but the other surgeons didn't think that was probably the greatest idea. And so we started losing these things, and the outcomes fell back significantly. And then under the new leadership, they expanded the nurse practitioner program that we had started, hired several additional nurse practitioners. And so basically these same goals were being achieved through the nurse practitioners who were now providing a different kind of leadership. The weekly meetings continued for a long time, but less participation. The daily rounds was now primarily nurse practitioner led, and the collaborative part of it began to diminish. But they were nurses. They were doing a great job of including patients and families. And everything started improving significantly. They developed some wonderful kind of data collection tools that standardized the way that they were working with the abstractors to be sure that they were getting everything exactly right that was needed. And bang, they achieved the 3 star. I mean, it was beautiful. And so over the next, but it didn't sustain. These nurse practitioners are basically now the glue that holds the system together. They have 3 and they're getting ready to hire a 4th, but they're getting exhausted. And of course, this last year was a terrible year with ECMO, and they're just, working like crazy. And so, whereas we were initially kind of building a structural glue, they showed that a nurse practitioner glue could work really well as long as you could sustain them. Also, they had a lot of leadership changes. And each leadership change, there's basically new orientation. So losing some of that connection, losing some of the leadership. And so they're hovering now. If you go to the current thing, you will see it as a 2-star program. But they said they just got a 3-star that hasn't been published yet. So throughout all of that, almost nothing changed in the operating room except the use of mammary arteries. And that was a slow thing. I'll show a little bit of data. I love this in one hospital where I worked. They had a little data closet and they put data on it. But so here's where Wesley started. 8% overall composite quality score, 15th percentile for inpatient mortality. All of the process measures just really, they weren't bad, but they were bad compared to everybody else. You know, the STS stuff is clearly a curve, and you know, it's for cabbage, it's 98%, certainty that you are, distinguished from everyone else. And so there were a few things, the outcomes that weren't so terrible, but this is where we started. And then here, just like to show, as we began doing this and focusing on these things and looking, so here were all the fallouts that just went away on discharge beta blocker, discharge statin, discharge aspirin. Eventually, we even quit reporting on these because they were just constantly 100%. And here's the journey of the percentile. Here's the setback when there was a leadership change, and then, no, here's the setback. Actually, this was our kind of journey, and then here's where the leadership change happened, and then they achieved this. Kind of long term, it was interesting. Almost all these changes are relational accomplishments. We were able to get the team that managed beta blockers together and working pretty well pretty early on. But the things that required a surgeon to actually change practice, it took much longer. We had to actually start the morbidity and mortality conference. Gradually, they would let the anesthesiologist come, then they would gradually let perfusionists come, and finally they would let nurses come. And by about this time, everything was really going well. But it took longer. So just a few lessons. It is inevitable that you will be uncomfortable if you open yourself to learning. We all kind of we've worked hard to get to the place where we are and the patterns that we know. This wonderful quote from Paul Euli and Don Berwick: every system is perfectly designed to get the result it gets. If you want a different outcome, you need to change something. And that change process is very much a relational accomplishment. One of the things that I've found really helpful is always assume positive intent. This is a beautiful phrase that I learned from a group of folks in an interprofessional clinic in Omaha. And this is kind of my little corollary, which is 90% of the time you will be right. People really they were trying to do the right thing. And the other 10%, you will still do better that way. So that's good. So I found this to be extremely helpful rather than get mad at people. Just go, I know you're trying to do the right thing. I also think there's a lot of efforts to mandate collaboration. And we're going to roll this out in our unit or whatever. People have to choose collaboration for themselves, but you can certainly invite them in. So these really function through invitation. This phrase I just love: if you want to predict the future, look at what you're doing right now. So if you want to know what your outcomes are going to be, if you are doing the same thing that basically you were doing, you're going to have the same outcomes. But if you start doing something different, you're going to get something different. And then this is a friend of mine who has been just a mentor and coach the whole time. She says, I'll do something, and I'll say, oh man, I just created a nightmare. And she'll go, so Paul, what did you think would happen when you did this or said that? I go, oh yeah, I should have seen that. So, these things are kind of predictable. If you're interested in these things, there's a website a group of us have put together. It's called createbettercare.org. And under this little tab called Helpful Resources, you can pull down a little book that outlines kind of how to do these things, and then also some things that we call a toolkit, a little call activation inventory and a resource inventory, and a little thing we call Team Finder. Here's an example of the resource inventory. Resources are like these capabilities that you've created among your team. Here's one: knowing what to do and what to expect to do. This is really from our research, from these high-performing teams. We have a collective intelligence. From our experience working together, we've developed a deep knowledge of the situations we usually encounter. This can kind of like, you can say, okay, read this, team, and does this make sense to us here? And can we do this? And does this matter to us? And from when people begin, they'll kind of say like, that's not what we're like, and it would be impossible for us, and really it's not relevant to us. And then further down the journey, they'll go like, yeah, actually this makes total sense, and it's not totally in our control. And so you can watch the growth of these capabilities using this inventory. And then this is about these preconditions. For example, this is this organizing for teamwork. The caring environment can be intentionally structured, staff and management teamwork in mind. This means organizing around a particular kind of care and establishing cohorts of people across professions. We're able to work together as a stable team with consistency and familiarity. Now, when you first hear this, you may go, oh, it's impossible, but it's not. And so this just offers a way for you to, kind of rate yourself. And then if you rate low, you can go back, and each one of these is actually an action step that you could take. Our system is organized so that patients we care for are always cared for in specific areas based on their needs and our skills, not randomly set where space is available. I'm not saying these are easy to do, but every one of these can be done and has been done. And just this wonderful little closing phrase that if one program can do it, you can do it too. So that was my talk for you. So I'll stop sharing.
Thank you very much, Dr. Uhlig. That was wonderful. I had great memories sharing that program with you when you started that up. And just the collaborative meetings and stuff that we'd have lunch together with all the different entities that helped with the patients is very nice to be able to see what everybody was doing to attribute to the patients and all. I think some of the things that the best parts of it, I think, was the collaborative information, the rounds that we did in the ICU, and the patients and the family members all participated in this. I thought that was so special, very appreciative. Whenever we could try to make the rounds, they loved that. I'd never seen that before at any other places I've traveled to.
And we loved having you, and the patients loved having you there too.
I know one thing also that we did in the operating room, when they wheeled the patient into the room, you had everybody introduce themselves and kind of tell what they were going to be doing in the room and how many years that they have been doing it. So I remember one time we gathered up all the years. I think we had 130 years of service in that room, and that patient goes, whoa, kind of, that was really fun days. Yeah.
There was one airline pilot, we did that, and he said, hey, Doc, really great pre-flight briefing. And there was another guy that was a coach, and he goes, hey, Doc, great pregame. So it was kind of fun. Yeah. But it was kind of taking the briefing to a little higher level of involving the patient and family, and or the patient in this case. And, like all these things, it was weird for people at first, and then it became much more normal.
Absolutely, yeah. And even the glitch sheet that we did, that was fun. I think now a lot of perfusion programs use the failure mode effect analysis, the FEMAs, to fix their problems before they happen. And this glitch sheet was kind of something similar to that also, and I mean, just writing down the things that happened today that just made your day not go as smoothly as you wanted, but it really, really helped move the day and the next procedure more smoothly, I think. But
the glitch is tied to that meeting. If you don't have the meeting with everybody there, then the glitch, what it's going to go to some manager and be one more sticky on his or her computer or whatever. Whereas if you have everybody there, you can talk about it and fix it right on the spot. There's a researcher who talked about type 1 and type 2 problem solving. Her name's Anita Tucker, and she's at Harvard Business School now. And she embedded with nurses and watched them solve problems. And type 1 problem solving, you basically push the problem down the road. And type 2, you fix it at a root level. And so this is really an infrastructure for that kind of root level problem solving in real time among a group of people. And again, that infrastructure, you can build it. And when you do, your life gets amazingly better. So happy to answer any questions or whatever, and honored to be here with you all. And David Norris, I saw your name pop up here. It's delightful to see you. So.
Dr. Uhlig, a terrific lecture, and we wish we had one of you in every one of our institutions.
Well,
Sure
you do probably, actually.
we do. We have to
Yeah,
identify them or do
yeah.
what are they calling now? Some reprogramming, I guess. But is there your data showing better medical care? The statistics, is that shared with the AMA, and is there any way to kind of push that agenda into the residency programs or to medical schools to try to spread the word that if we can instill this as a root within the training, that perhaps more individuals might practice that once they're out and being leaders within their own teams?
Well, it's really an interesting. I've spent 20 years trying to build these environments, and that includes education and so forth. And there's definitely receptivity and interest. Last several years till COVID, was working for the ACGME doing site visits and so forth related to residency programs, and I just love that. And even so, almost every one of these environments that we built flourished, produced extraordinary outcomes, and usually doesn't exist in the same way anymore. And the loss of that was really painful for me at first. And then I began to understand differently. We've done an extraordinary job as a society and as health professions of standardizing around an old model. And it's in our payment processes, our education processes, even our research processes, as well as our practice processes. And so you painstakingly move a practice out, but all these other things will snap everything back to where it was. How our organizations function, our expectations of leadership, all these things. And so those of us who do this work have become at peace with the fact that we will probably have short-term successes for a while, and then it's almost going to be like a field shift, that the education will change, the practice will change, the research will change, the payment will change, and then suddenly pop, will be in this, what some of us call the second curve of healthcare, this exciting new paradigm. Many of us are still in curve one, and it's a time of sadness and loss, because we know that these ways are no longer meeting the needs. We've devoted our lives to them. But an increasing number of us have moved beyond that, done that grieving, let it go, and are now actively engaged in building these new ways of working. And it's like, the birth of the new. It is thrilling. Your skin will tingle when you are with people that are working in these ways. If anybody's interested, I'd be delighted to visit more. I know you all are doing a great job of staying right on time. Thank you for the privilege of sharing these things here. So.
Are medical societies as receptive to having talks like this? It's probably society specific based on my experience, but what is your receptiveness there?
It's actually, there is a receptivity. When I first started doing this 20 years ago, there would maybe be 5% of doctors would find this really interesting, and they'd come up and talk to me afterwards. It's now 35%. It's not a majority, but it is a significant minority, and there is definitely a shift. And we're expanding this collaborative approach now outside of cardiac surgery. I've had the privilege of working most recently with several internal medicine resident teams in San Antonio and other places in Michigan. And so the approaches can be transported outside of cardiac surgery. It's this creating team learning. So, but thank you for asking these questions.
Quint Studer has a book out called The Busy Leader. He's written about 5 books, and he basically uses it in the hospital setting. He used that same philosophy for years. Now he's expanded into communities, into businesses, to every part of he's found that, these programs like this not only thrive, but they basically bring everybody together in a collaborative world. And they can iron out problems when they have them much easier by doing it this way than they do others. It's a book I think we're using with our program now called The Busy Leader with Quint Studer. I don't know if you're familiar with that. He's actually from this?
I'm not familiar specifically with that book, and I appreciate knowing that. Thank you for that.
Thank you very much, Dr. Uhlig, and your leadership in this role. Appreciate it. Thank you for joining us.
Privilege, and thanks for what you all do every day for every patient, every team. Thank you.
Thank you.